Jumping right in, here is our intumescent cataract.
The first surgical challenge of this case is creation of a continuous curvilinear capsulorhexis using trypan blue and phaco-decompression techniques.
We've just attempted decompression with a 27-gauge needle bevel up, giving some time and we can see the fluid extruding from beneath the lens capsule. Unfortunately, the high intralenticular pressures have led to a rapid uncontrolled tearing of the capsule all the way to the lens periphery, which is what we colloquially term the Argentinian flag sign. Going in with intraocular scissors to create space to the nucleus and remove as much of the anterior capsule as possible. At this point, we will skip hydrodissection. Hydrodissection in this case would put undue pressures on the weak points of the anterior capsule, leading to radialization and possible nuclear loss. Thankfully, the lens is soft enough we can begin our nuclear disassembly with a low bottle height upon entry and performing a trivide technique. Thankfully, the pieces of this cataract are relatively soft due to the patient's age and pathophysiology of this cataract. After gently separating some of these pieces of the nucleus with the chopper, we can then begin to use aspiration mode a little bit more aggressively to pull forward some of the nuclear chunks, using the chopper to guide them towards the phaco-needle, keeping the phaco-needle relatively centered. Now we're starting to see the majority of our nuclear material be separated from the bag, and we can begin to aspirate this into the phaco-needle with relative ease. Here we're just gently keeping the foot pedal in position 2 and 3, using the chopper to manipulate pieces towards the phaco tip and keep it in the protective position to prevent aspiration of the capsule. Here we have insertion of a single piece intraocular lens, not totally into the bag, and we'll use a Sinski to gently manipulate the haptics with as little tension on the capsule as possible. Only half of the IOL was inserted into the bag, leaving the trailing haptic out. We can now just gently insert it using a Sinski hook to minimize as much force on the capsule as possible. This type of lens has very little cortical material, and additional polishing and cortex removal was skipped in this case to avoid tearing of the capsule posteriorly. Thankfully, no cortex was in the visual axis and OVD was removed gently. And stronger postoperative steroids were used. Now that OVD cleanup has been completed, we'll begin irrigating the eye with a cannula while removing the IA tip to maintain the chamber. Gently hydrating our wounds and checking that the pressure is physiologic. Now at the end of the case, we're inserting myostatin and dexamethasone. We can see some OVD floating around the eye, so the patient was also given Diamox to go home. Moving right ahead, we can see this is the patient's fellow eye. This surgery was done approximately 6 to 8 weeks after the initial eye. And now we'll begin to employ some techniques to help prevent an Argentinian flag sign. Having gone in and making a small hole with our 27-gauge needle, we're gently balloting the anterior capsule with the ball tip chopper very safely to remove any hidden intumescent fluid. Using our phaco needle on our sculpt setting in position 2, we're aspirating as much fluid as possible, gently pressing onto the nucleus here and there to make sure any fluid from behind the nucleus is allowed to escape. Now we can go ahead and proceed safely with our continuous curvilinear capsulorhexis. As you can see here, there was no Argentinian flag sign, but the rhexis was quite small. The case then proceeded normally, and at the end, intraocular scissors were used to snip the anterior capsule at the nasal edge to prevent capsular phimosis.
The patient was happy and had a good outcome. Thank you for watching.